Hey everyone, it's Victoria, and today I want to talk to you about the three biggest misconceptions that people are having with the 2021 E&M changes. If you're new to my channel, I'm Victoria. I'm a medical coding instructor, and I like to look into all kinds of different topics in medical coding, some of the hot things that are going on in the industry, examination tips, and just things that might help healthcare professionals understand the world of medical coding better. Today I'm going to talk about those 2021 changes. Now, at one point, Medicare had said they were going to collapse some of the codes and reduce the payments to basically a fee for a level 1, a fee for a mid-level, and a fee for a high level. That's not happening anymore. The AMA put out some great changes of what's going to happen in CPT come 2021, and CMS says that they are going to largely adopt what has been suggested by the AMA. So that means that they might take some of the things that the AMA has pinpoint it and kind of further define what's going on, but for the most part, largely what's going on has been adopted or will be adopted in 2021. Obviously, this is a big change for our industry, so there's a lot of different discussions going on about this, and there are some misconceptions going on. The biggest misconception right now is that all of evaluation and management is going to change. If you open up your CPT book and go to your evaluation and management section, evaluation and management encompasses a lot of different visit types. It's outpatient visits, inpatient visits, newborn care, preventative medicine services, skilled nursing facility care, prolonged care, critical care. There's a lot of different types of visits that are E&M visits. What's actually changing is our office outpatient visits. So codes 99201 through 99215 are what is changing in 2021. There's a lot of hype going around saying, oh my God, all of evaluation and management is going to change in 2021. And what that's usually followed by is, oh my God, get ready. If you buy our product for $1,000, we'll prepare you for the big changes that are coming in 2021. Don't buy it. Don't hit that panic button and start subscribing to things that are going to cost you an arm and a leg. There's going to be a lot of great resources that are going to come out between now and 2021 that are going to be much better than whatever these panic-stricken organizations are trying to throw at you for purchase. This is healthcare, not professional wrestling. There's no reason to get excited. We're not tackling Macho Man Randy Savage over here. The second biggest misconception is that you no longer need to document a history or an examination. I don't think anyone is intentionally doing this wrong, but you do have to be very, very careful about the way that you are wording this when you present it to others. It's not that history and examination are being eliminated completely, that you don't need to do them or that you don't need to document them. It's that they are no longer being factored into the level when selecting your level of service for office outpatient visits. For example, you might have a patient that comes in with anxiety and you give a lot of great detail of history of what's been going on with that patient, things that are happening in their lives, things that are triggering their anxiety, but you might not really fit into where the location of the anxiety is or the quality of the anxiety. And now you can just focus on what that quality information is, that quality history that you're providing, without having to worry about, oh, does this disqualify me from selecting a level 4 service because I didn't hit those specific bullet points. So if you hear anything from word of mouth or through society saying history and examination no longer need to be done or documented, it's not exactly true. They just don't factor into the selection for evaluation and management anymore for codes 99201 through 99215. So perform the medically appropriate history, perform the medically appropriate examination, document the medically appropriate history, document the medically appropriate examination. What you don't want to do is examine a patient and have pertinent findings and then not document it, because that could lead to a liability. The third biggest misconception is we're all going to lose out on a ton of money because all of our levels are going to get down-coded. Unless you're someone that's been coding a lot of level 5 established patient visits just based off of history and examination, you probably won't see too much of a decrease. I think where we might start seeing some changes are some level 4s for acute visits might start going to level 3s for acute visits. So for example, we've lost now the concept of a new versus established problem. We still have new versus established patients, but the new versus established problem has left, which means that you no longer get 3 points for a new problem with no additional workup. So because of that, even if you're giving prescription drug management, it might not necessarily hit that moderate decision making for a level 4 service. It might drop to a 3. So if you were previously getting 4s for those, you might start seeing some level 3s now. But again, everything still comes down to documentation. Even though the history and examination piece has mostly been taken out, it still is a lot of documentation of that thought process going into your medical decision making. If you're watching this on another platform like LinkedIn, make sure you head over to my YouTube channel and subscribe because I've got a lot more great content coming. Thanks everyone, and keep on coding on.